Dear viewers, welcome you all to our show OSA, that is Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is Ilizarov for the correction of deformities caused by metabolic disorders. Very difficult cases. But we all know that our legendary Ilizarov surgeon, Professor Mofakrul sir, can make the impossible things possible by the magical Ilizarov. So that today our speaker is Honorable Professor Mofakrul Barisar. I would like to request Professor Mofakrul Barisar to join with us.
Good afternoon, everyone. Thank you, Tanveer, for introducing me.
Good afternoon, sir. Dear viewers, we have three learned academic experts with us. One of them is the highly academician, Professor Novikov sir from Kurgan, Russia. I would like to request Professor Novikov sir to join with us.
Good afternoon, dear colleagues.
Good afternoon, sir. Dear viewers, we have Dr. Omar sir from Kurdistan, Iraq. I would like to request Dr. Omar sir to join with us. Good afternoon, sir.
Good afternoon, everyone. Thank you so much for your kind invitation.
Good afternoon, sir. And we have another enthusiastic Ilizarov surgeon from Patna, India. That is Dr. Shamsul Huda sir. I hope Dr. Shamsul Huda sir has joined with us. Sir, welcome. Welcome to our show.
Thank you.
Dear viewers, metabolic disorder, we all know that it's a very difficult thing for all orthopedic surgeons. And the deformity caused by this metabolic disorder can be corrected by Ilizarov. And our honorable speaker, Professor. Now, I would like to request Professor Mofakrul Barisar to share his screen and start his presentation. Sir, would you please share your screen with us?
Okay. Thank you, everyone. Dear friends, can you see my screen?
Yes, sir. You are completely visible and perfectly audible,
sir. Today, I'm going to talk on a very, interesting and difficult case, the metabolic disorders. The surgeons sometimes may confuse regarding what are the diseases goes under the banner of metabolic disorders. And when patient is suffering from metabolic disorders, he may have some very different and difficult types of deformities, which are very difficult to manage by the orthopedic surgeons. And today, I want to share my experience with these deformities that was caused by the metabolic disorders. And my places, this is again my current working place in Dhaka, two most very big hospitals in Southeast Asia, my center, and I always love to show the Professor Ilizarov, who has done a lot of things for the human beings. When you are talking regarding the metabolic bone disease, it includes many hereditary and acquired conditions of diverse etiology that lead to disturbed metabolism of the bone tissues. What can metabolic bone disease cause? In clinical terms, metabolic bone diseases may result in bone pain and loss of height due to compression of the vertebra, and they predispose patients to fractures. The diseases under the metabolic bone disorders, you can see here, I have sequentially just placed these names: osteoporosis, rickets, we are getting often in children, and in adults, osteomalacia, hyperparathyroidism, Paget's disease of bone, marble bone disease, or Albert-Schoenberg disease, that is we call the osteopetrosis, fibrous dysplasia, and osteogenesis imperfecta. So, commonly we know this is osteoporosis is the most common metabolic bone disease, and its name literally means porous bone. Rickets is a condition that affects the bone development in children. It causes bone pain, poor growth in soft tissue, and weak bones that can lead to bone deformities. And in my country, we're getting a lot of cases that patients are suffering from rickets with the deformities. And osteomalacia characterized by the softening of the bones caused by impaired bone metabolism, primarily due to inadequate levels of available phosphate, calcium, and vitamin D, or resorption of the calcium. And Paget's disease, which is known as the osteitis deformans, is a condition involving the cellular remodeling and deformity of one or more bones. PHPT, that is hyperparathyroidism, is a common disorder in which parathyroid hormone is excessively secreted from one or more of the four parathyroid glands. And again, this fibrous dysplasia is an uncommon bone disorder in which scar-like fibrous tissue develops in place of normal bone. And Albers-Schoenberg disease or marble bone disease, in this case of disease, you can see the bone marrow cavities become filled with compact bone, and very difficult to treat this marble bone disease. And osteogenesis imperfecta, also characterized by brittle bones that fracture easily. Now, regarding the deformity correction, if you want to go for acute correction, you can get this immediate restoration, early return to life, and patient will feel comfort. But at the same time, if you go for acute correction, you may invite neurovascular injury, compartment syndrome, suboptimal correction, and you can get the non-union also. But when you are using the implants, in case of deformity correction, you have a external fixator Ilizarov. You can go for IM nailing. You can use the plate and screws, and at the same time, by simple covers and placement of the cast, you can correct the deformities. But in case of metabolic deformities, you can see here what are the problems: produced growth plate disturbances, defects in bone mineralization are seen mostly in infants and children, multi-apical deformities. If you look at this chart, this is Winsor deformity, look at these, and multi-apical deformities. And prior to any surgical intervention, all hypophosphatic patients require appropriate metabolic management. Surgery should not be performed until the laboratory parathyroid bones return to normal. So, deformity in metabolic disease, as I told you earlier, you can see the multiple complex deformity, poor bone quality. You must keep it in mind, the three problems, and you can go for acute correction or high-tech implantology. Nowadays, most of the orthopedic surgeons, those who don't have any idea regarding the Ilizarov, they're going for fixator-assisted nailing, and you can use for that. But in my country, due to the the quality of bone is not good, we are going for gradual correction by Ilizarov technique. Now, X-ray accuracy, minimally invasive, and safety. IM nail, patient compliance, comfort, no external fixatum time. These are the cases that you can correct by external fixator Ilizarov or fixator-assisted nailing. Now, look at this, what we have done since 1990 to 2021. 57 patients, 144 limb segments, 14 hypophosphatemia, and 2 renal osteodystrophy. All patients are metabolically normal at the time of operation. Look at this, severe deformity with patellar dislocation, tracking, and this is Winsor. This is a bowing of the femur, and at the same time the tibia. Now, I would like to share my experiences with the case presentation. This is a 12-year-old girl, bilateral bowing of the femur and bowing of the tibia, or O-type deformity. You can see here, quality of bone is not good. Now, if you draw the lines, hip to the ankle, see mechanical axis deviation. This is totally O-type deformity. So before going to do any surgery, you must have radiographic view from the femur and from the tibia, and whole length of the femur, whole length of the tibia, 2, 3, as well as the ankle. Now you can see how she is walking. Look at this. Very difficult case, O-type case. This is due to the ricket. See, young girl.
Bus.
And now you can see here what I have done. Just look at the first. I have done the osteotomy in the femur. I am going to show you the later on. And this is at the same time, patient is walking with this, walker during treatment. At the same time, after doing the right side, after 7 days, we have done this left side. And simultaneously, you can do I have done the 4 segments, femur, upper, left, right and left, and tibia also. Now you can see here, radiographic view with Ilizarov fixator, double osteotomy for correcting the deformity in the lower tibia. If you draw a line in AP view and lateral view, you can see the mechanical axis of the tibia is almost corrected. Now, how many rings we have put here? 1, 2, 3, 4, and with olives, and you can, at the same time, while we have done the osteotomy, at the level of the osteotomy, you are putting the hinges. This is very important. And follow up after 3 months. See, you can see here. And this is, you can see, follow up after 5 months. Now, from this situation, look at this femur, mechanical axis deviation, and the TB also. Now you can see here, radiographic view of this one. Patients with tibial varus malalignment, preoperative mean MPTA was 80 degree, and postoperative we got 87. That is the normal. Minimum, this is the mean MPTA. Now you can see here, before this one, and after, before and after fine correction by Ilizarov technology and the apparatus. Now let us see again another case. Look at this, dear friends. Bilateral genovalgum with patella tracking. Look at this. See, what is the patella? This is the marking of the patella from the front view and back view. You can see the X-ray, and this is the radiograph. And then undergoing rehabilitation after fixing with the Ilizarov, and then radiographic view, osteotomy in the lower femur, and you can see before and after full correction. Gradually, it took 11 months to correct the whole femur, patella, and look at the ankle, look at the foot, look at the ankle, both sides. And from the back, you can see here. Now, dear friends, you can compare this one, back side with this, and front view, this one with this. And this is the full length X-ray before surgery, and this is you can see here, almost corrected the right side and the left side. And you can see how he is walking and we're jumping, moving. So look at this. These are the very difficult cases you can correct with this magical Ilizarov technique. Now, I would like to share you again multifocal lower limb deformities. In rickets, we can see here valgus of the right and varus of the left. This is front view, rear view. You can see the deformities in the femur, in the knee, at the same time in the ankle, and deformities here. This is called windswept deformity. And renal tubular rickets, familial hypophosphatemia. Before treatment, during treatment with the Ilizarov fixator, you can correct it by placement of the doing osteotomy here, and placement of the hinges. This is the after correction. These brothers presented with knee deformities. He is younger brother of that child. And now this windswept deformity, comparison of pre and post-operative scores. Before surgery, the patient will complain, pain, limping, walking quality, proximal range of motion, and distal range of motion. So paired samples test regarding all these 5 points. See, good quality correction. And then you can go for another case. See, this is a fibrous dysplasia of McCune, that is Albright syndrome, 13 years old child. Look at the back side of the girl, 13 years, very big coffee outlet. I have shown you this one, that in the back side. And look at this valgus and how she's walking. Bone quality is not good, poor quality of the bone, valgus knee with 5 centimeter LLD. And then we started doing correction with Ilizarov fixator. I always try to fix when the bone quality is not good with the multiple K-wires or olive wires. And you must suggest to patient to go for exercises after doing the Ilizarov surgery. And patient is doing exercises with Ilizarov surgery. After Ilizarov surgery, you can see here, see, allow your patient to go for exercises in the fixator in the upper femur and in the lower tibia. So now you can see during treatment, after 3 months follow-up, dear friends, and finally you can see the X-ray, the whole length almost corrected. Look at these, 3 centimeter LLD and deformity in the knee was also corrected. So this is before, this is after treatment. Now you can see here, just after removal of the fixator, patient was allowed to walk with a walker. And before that, he was walking like that. You can see, just you can compare. So McCune or Albright syndrome or disease, the bone quality is not good. So all these types of cases, you can fantastically correct by Ilizarov technique. So this is the beauty of Ilizarov when you are using this kind of, in these kinds of patients. So this is a case, another, sorry for the movie, just opposite to the not normal situation. Look at this. This is genovalgum due to rickets. You can see the whole length of the femur and tibia, mechanical axis deviation, deformity of the whole tibia. You can see, and now at the same time, you can see the posture of the whole patient and the body of the patient, and you can see the valgus deformity of the knee, and at the same time patellar tracking. Now what we have done, just if you look at this, we have done the osteotomy in 2 levels. Here, 2 levels, here, and the lower femur. And we have done the right sided first time, and then after a few days, we have done the left sided. And patient is allowed to walk with this fixator. Now, you can just compare the tibia and the fibula, and after correction of the tibia and the same upper part, lower part of the femur. So this is before. Just when you remove the apparatus, you just allow the patient to go for after fixed removal. After removing, dismounting the apparatus, you just put the plaster, and after 3 to 4 weeks, then you remove the plaster and allow the patient for bracing with hinges in the knee, so the patient can go for exercises, for knee bending exercises, and patient can walk with the braces. So this is the case. This is, you see how he was walking before, and this is after after the treatment, and patient is walking nicely, and deformity is fully corrected with the braces. This is the case that we have done, very difficult case. On an average, 6 months to 11 months, even 12 months, it takes time to correct the deformity in 4 segments. So this is a case, very simple, 2 years. I would like to share again this 2 years old boy. Parents insisted to go for the correction. And then I advised not to go for early age, but you can do that when the parents are very much interested to go for deformity correction. Very easily you draw the lines from here to here, and then you can correct here. You can correct here easily by doing the osteotomy and putting the Ilizarov. You see, children always takes Ilizarov apparatus very nicely. See, we have what we have done and put the fixator. Here is the true apex of the deformity. Here also the true apex of the deformity. So radiographic view you can see here. So this is after treatment, nicely corrected, and you can see here this is before and this is after the treatment. Before and after the treatment. Now, very difficult and severe cases. Patient is living in Dubai. He came to Dhaka just for treating, consulted in different parts of the different countries. Now look at the bone quality, dear friends. Deformities of both lower limbs. 15 years old boy. Look at the femur here and look at the lower end of the ankle, and you see the 15 years growth plate is almost going to be closed. Yes, still it is visible. Now if you draw the lines JLCA here, now you can see your mechanical axis and mechanical axis deviation, whole limb. See, it is not through the knee joint. So now look at the ankle from the front side and look at the ankle from the back side, and then see opening wedge. What we have done: first osteotomy, second osteotomy. You see step 2 osteotomy here, osteotomy, and 3 gradually you go for distraction. Coming up it is opening wedge here. Now you just see the placement of the hinges and at the same time placement of the rings and placement of the first ring, placement of the second ring, and placement of the last ring, that is third ring, with hinges. Now gradually you are corrected. You are just lengthening. You have done the 2-level osteotomy, proximal and distal. See here and see here. This is step 3. And then you can see here step 5 going on. Gradually it is opening wedge. If you draw a line, look at the ankle. This is the anatomical and mechanical axis almost corrected. Look at these. This is AP and lateral view. And this is the, you see how widening of this opening wedge is going on. See the level. Now draw a line. This is almost corrected. This is the final radiographic view before dismounting the apparatus. So dear friend, you can see here, before doing final correction, you must draw when you are taking your patient to the OT, before that, you must draw the angles. You should have to keep it in your mind, the different angles in the hip, in the knee, as well as in the ankle. Now, you just compare. Gradually, you are correcting these kind of deformities by putting the hinges with Ilizarov apparatus, and at the same time, the bone quality while you are doing osteotomy and after giving the distraction, you will get a very good result. Now, this is the case. Again, I would like to share my experience with the case. This patient with fibrous dysplasia, the diagnosis was indifferent. His parent came to my place after going to different places. The diagnosis was different. Somebody was thinking about that this is not a fibrous dysplasia. Then we have done the operation and we have taken the biopsy from 2 places, and biopsy has given that this is a fibrous dysplasia. What we have done, remove the whole segment and then 3-ring construct. Here you can see here, putting the one olive oil from their side, then gradual bone transportation to upwards. Look at this. what happened. And this is finally we could achieve the, the bone transportation. And this is the view of this, removal of this. And now if you look at this, the pathology was here, it was removed. And then finally, this is the lateral view and AP view. And this is the case that I'm going to share my last experience with this one, with osteopetrosis. See, very difficult case, hard bone. This is a compact bone filled with the cavity, whole cavity with the bone, compact bone. This is a young lady, 30 years, came to my place. And then what we have done, look at this. Sometimes we need to go for, shunt pains in the upper part of the femur due to the anatomical constraint. Look at this. This is the pathological area, fracture area. Put the shunts, and here is the shunts, and here is only the wires. And then allow the patient to go for walking. And after dismounting the apparatus, this is the final view. Sometimes it's very difficult to go for nailing of the marble bones of osteopetrosis disease. So these are the cases that I have shown you under the banner of metabolic disorders. Again, pathological fracture, bone quality is not good. You can see here the fracture here. This is the pathology, whole upper and lower. Again, he was treated elsewhere by DHS. You can see here. What happened then? Then we have to remove that one and corrected the, angulation here with multiple K wires putting through the neck of the femur. And these are the console wires that are not passing through the second cortex to cortex. And then we have corrected the angulation. We have not given any kind of, bone grafting. Just you allow your patient, after putting the Ilizarov apparatus in proper way, you suggest your patient to go for weight bearing with the Ilizarov fixator in the thigh. And we always allow the patient to go for ladder. We have a physiotherapy rehabilitation center. We allow our patient to work with this kind of Ilizarov fixator by multiple K wires or olive wires and go for exercises. Now you can see here, dear friends, from this situation, from pathological fractures, DHAs, and this is the quality. You can see a little bit deformity here. So this is acceptable. Lateral view you can see here. So this is Paget's disease, same pattern. See, I told you that multiple signs of osteogenic sarcoma in a patient with Paget's disease of the right hemipelvis. And if patient comes with these types of deformities, again the same way. If we draw a line here, draw a line here, this is your true apex of the deformity. By doing a single one osteotomy, you can correct, or you can go for two osteotomies here. One is here, one is here, and gradually you can correct these kind of deformities. So these are the cases that we have treated, and the complications, no loss of correction, no infection we have seen during the treatment of these metabolic bone disorders. And in my conclusion, dear friends, I would like to say the result is excellent when you are using Ilizarov fixator. Needs good expertise for Ilizarov surgery. No risk of emboli. You can go for fixator-assisted nailing. You can do that, but you may invite emboli. But in case of Ilizarov, there is no risk of that. And hospitalization period is little bit longer because you need to control all kinds of, activities after putting the Ilizarov in the patient's limb. And we can get, after the treatment, better range of movement, better cosmesis, minimal invasive surgery, no recurrence of deformities. and that I have shown you. These are the deformities that we have published in different journals. This is osteopetrosis, you can see here, again medical journal. This is the tibial fibrous dysplasia in children. Again, we have published all this. And I always love to say that Ilizarov fixated and biological principles of these gradual destruction revolutionized the management of limb deformities. Look at this, dear friend. Limb length discrepancy, bony and joint contractures, soft tissue contractures, bone loss, delayed and non-inus. You can control the infection. You can go for transverse destruction and ischemic lean disease. You can correct simultaneously by this fantastic Ilizarov technique. And why Ilizarov? Ilizarov, if you compare the left side and right side, I myself always think that if you see the alphabets of Ilizarov, it means you must have some intelligence when you are using Ilizarov, that is I. You can go for lengthening whatever you want to do. Again, I, you can control the infection. Z, you have a zigzag. You can correct any kind of deformity. You are getting angiogenesis that is adaptable and emerging, reliable. Of course, you have a lot of opportunities by the Ilizarov apparatus. And finally, you are getting a victory, and this is versatile. And Ilizarov feel any defect in life of bone. When you are hopeless in orthopedic treatment, you must think to Ilizarov. The difficult cases, you can treat with this fantastic technique. The extended life of quality, you see that I have shown you the different difficult cases, and you can lengthen, you can correct by this fantastic technique. When all lights are off, the light of Ilizarov is on. An unbelievable event you can get by Ilizarov technique. You can, whenever you are finding any kind of disability, and disability ends by Ilizarov. And we have a bright future in disability by Ilizarov technique. So these are my patients and my friends. All you can see here. This is Novikov, Shevtsov, no Shevtsov here. Shevtsov is another case here. And we are doing surgery in Bangalore. This is in Ramaya Medical College Hospital. And my team and here. So carry home message. These are the things that I have shown you. This is always on the basis of evidence. Of course, Ilizarov is always science and surgical skill of the surgeon. And whenever you have all these things, you can do something with this fantastic technique. Finally, this is my 94 international articles published, 7 books, and I finished already the third one, 8th one, that is the upper limb. Within a short time, it will publish. And thank you very much for your kind attention. And this is the man that I must pay gratitude to this gentleman, and at the same time, his successor, Professor Vladimir Ivanovich Shevtsov. And thank you very much for giving me the time to talk on these difficult case, metabolic disorders by Ilizarov. Thank you again. Okay.
Thank you, sir. Thank you very much. That was an excellent presentation, and I think it was a historical presentation, as because of lots of difficult cases in a single presentation. Now, I would like to request Professor Novikov, sir, to say something regarding the presentation.
Dr. Bari, спасибо тебе от русских врачей. Thank you very much from our Russian colleagues. And today we can see difficult cases with metabolic disorders. And this is not our job. Because, for example, rickets, this is patient need take care from urologist, from in other specialties, and during the treatment by Ilizarov, Professor Bari, did you support this patient with biphosphonate, with another calcium? Yeah?
Yes,
This is you was alone or collaborate with
no. You must take the yes. That's why I told before doing surgery, you must have all these tests and take the urologist, and at the same time, even the pediatrician, you must take consultation from them. And regarding the deformity, then you can handle that one.
And Dr. Bari, can we together just now again to see one patient, case number 6? Can you show? This is very difficult case, and just now only technical questions. Why you have different position between fibula on the right and left, and how you start? Because sometimes difficulties or errors give us a new technique. This is all errors our teacher. And can you show, Dr. Bari? Case number 6.
I understand. That is from Dubai.
No. Can you show picture? Because one fibula is excellent, another fibula
diverted. No, it doesn't hamper. It doesn't create any problem. It doesn't. I understand your question. It does not create any problem. No problem.
Why, Professor Bari? Why we have different position, different view? What you see? I'm not asking about complications. I am happy with final result.
Yes, very good question that you have answered. You have asked me. When I have done the osteotomy, the fibula was rotated. Rotated. It was not like right and left, not the same. It was rotation. Yeah. Then I have not thought about that one. When I have done the osteotomy in the upper level, in the fibula, and in the lower level, it was just rotation and 2 more, deviation from the normal position. And I thought it will keep like that. I have not touched that one. And that was the problem. No problem with the patient's, mobility and other things. Patient does not complain any kind of problem. That's why I did not touch that one. I have kept that one in that way.
No, my question is, did you fix in proximal part cap of fibula?
Yes, no? I have fixed that one. Yes, I have fixed that one. You thought that I have not fixed that was debated. I have fixed that one, proximal part.
Yeah. Thanks a lot.
Okay.
Thank you very much, sir. That was a great discussion. Now, I'd like to request Dr. Shamsullah sir to say something regarding the presentation.
Thank you, Bari sir, for such a wonderful lecture. It was a wonderful learning and legendary cases, sir. I just have one small question. In sir, periodic severe deformity like Paget's and cystic diseases, what is the rate of recurrence with the growing age, and how many cases you need to do revisions in an average, sir?
You repeat the question again.
Sir, like in difficult periodic complications, deformities, cases that you have done, like in Paget's disease or like in cystic fibrosis cases, which have severe deformities, when you've done it at the age of 5 or 6 years, till the children grow at around 16, 17 years, what is the rate of revision cases that you have been doing, sir? The recurrence of deformity and revision surgery?
No.
Metabolic diseases, yeah.
That is deformity. You just repeat that. The sound is not coming to my place. Again.
Sir, yeah, revision as growing age.
There's a vibration in your asking questions.
Okay, sir, just a minute, sir. Yeah. Dr. Tanvir, could you hear my voice?
Yeah. I can hear your voice clearly. Would you please make
sporadic interruption?
Can you put my question for him?
Okay, definitely. Sir, Dr. Shamsullah sir is asking about the recurrence of this Paget's disease as because of you are treating the patient in the age of 5 to 6 years, or then what will
Yes.
happen in the years of
Recurrence
16 or
rate. Yes,
17? Yeah, yeah.
I got the question. If you correct the alignment all the time at the age of 5 and 6, and you just allow your patient after removing the apparatus to go for 1, 2, or 3 years with the braces. If you see there is no deformity, recurrence is going on happening, then you stop the application of the braces. Otherwise, you should have to advise the parents to go for braces for 1, 2, or 3 years. When you started after 5 or 6 years. Even then, I have shown you the one case at the age of 2. These parents insisted me to go for that I have done.
Right.
Still, patient is coming to my place. I could not show you that long follow-up. Patient is okay, no problem. So you must tell them to go for, with this correction, vitamin D, use of braces, and long-term follow-up. Otherwise, you will not have any problem. And I have not seen in my case the recurrence rate. Okay.
One more question, sir. As growing age, like just we have a crooked hip or something like that, do you need to give an internal fixation like PFN when the child grows in an adolescent age?
No. See, those who are using fixator-assisted nailing, they are doing that. But I have not put any kind of nailing inside. All these cases that I've shown you only by Ilizarov fixator doing the correction, mechanical and anatomical axis, nothing else.
Just to avoid repeated deformity or refracture. No bracing.
No.
Okay, sir.
No.
Thank you, sir.
Thank you very much, sir. Sir, I have one question. In your last slide, you have shown us that you are using the console wires in case of fibrous dysplasia.
Yes.
Sir, what is the role of this console wire in case of fibrous dysplasia?
Whenever you are drilling any wire, you are increasing circulation. This is the theory. And console wire, that is one wire coming from one cortex to first cortex to second cortex, it doesn't pass through the second cortex. And with the normal wire, if you use another 2 or 3 or 4, you bend like these wires, or you fix it with multiple wires, it gives stability, not like the full wires, tension wires. So you can use multiple console wires to increase circulation and for more stability with the normal wires, that is crossing wires. So this is the console wire. When you have done lot of spaces, you can put the multiple console wires in place where there is a fibrous dysplasia. To increase circulation, you can use multiple 2, 3, 4, or 5 console wires. Console wires, whenever you are putting like this, you can bend like this. You can bend.
Okay, that's great. That's good. I think the network is jamming there. And it was a great discussion as because of lots of difficult cases we have seen in the presentation of Professor Mofakarul Bari said. Dear viewers, we think we have learned a lot from this presentation. And I would like to thank Raj TV for helping us to arrange this type of academic program, and definitely Renata Pharmaceuticals Bangladesh Limited for sponsoring our programs. Dear viewers, we hope we'll meet in the coming Friday with another Ilizarov topic. Till then, I would like to say bye-bye to all of you. I'm Dr. Mohtan Rashab saying bye-bye to all of you today. Bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe.